The flash is not true. The flash is from 1.5. Okay, USB. Okay. What is this? Okay. Copy, just copy. Okay. Copy and paste. Okay, no problem. It's fine. Yeah, it's fine. It's fine. Okay. This one? Yeah. Okay. So you don't stop you can do the yeah, I've done that. I've done that. Yeah. This, who is the chair? It's meant to be secure. I don't know. This person is going on. So, I don't know. I think secure arrows. I see secure. It's not the chair. It's a chair, so and it's also a panel. It's just a four of us. Okay. Should we wait for Dr. Azesigi? I guess we can continue and then already complete. So who's going to chair? Maybe you should share. It's carry on. Okay, so good evening. Good evening, everyone. It's a pleasure to be here this day. And okay, I'm deciding for the chair. My name is Nambala Palute. I'm a doctoral student at State University of New York at Buffalo. So I will be standing in for the chair. And on this panel, this panel is titled Nigerian History, Colonial and Postcolonial Periods, Part 3. So on this panel, we have 4 presenters, including Adewale Onopesong, Damilola Fagite, myself, and then Ononiwo Opara. Ononiwo Opara. Ononiwo, I'm so sorry for that. And then lastly, we have Assist Secure. So I'm just going to call on, not at the same time, I'm going to call on Adewale Onopesong to present. And then you can, introduce yourself and then you can present. But before then, I think we have 1 hour, 30 minutes, if I'm correct. So each presenter will have 12 minutes to present. I think that is fine. And then the rest of the period, we will use that for Q&A. So anyone? All right, thank you so much. Let me say, doctor in the process, she's somebody who's work inspired me, so thank you. It's lovely to meet you here on this panel. My name is Adewale Onopesong from the University of Lagos, and I'll be presenting my work title to bear the Black Man's Body, historicizing the experience of welfare personnel in Nigeria. It was just a lovely afternoon while doing my archival research. And
flipping year to year. I got to the annual report for the year 1921, and specifically on page 26. I read a paragraph that drew my attention to the cost of this work. And just to put some context, the paragraph is so, while presenting the report for the year 1921, the Chief Principal Medical Officer said, although in the foregoing paragraphs, an effort has been made to paint the conditions in which our medical staff in remote outstations strive, in quotes, to bear the black man's burden. End of quotation. It is difficult to give an adequate picture because we was trying to explain the experience of healthcare personnel across various provinces and districts in Nigeria at the time. And the quotes, in quotes, to bear the black man's body, drew my attention, and I looked further. And it leads me to the point of emphasizing the specialization of healthcare experiences during colonial Nigeria, both in terms of kind of things that were controlled and the generosity, as the case may be, of the colonial authority towards Nigeria in terms of the investment in infrastructure, investment in disease control, and so on and so forth. And in this case, their discussion towards labor condition, healthcare labor condition during this period. So my work departs from conventional emphasis on this history, like a number of scholars like Vaughn has focused on focusing on various diseases. Nancy Hunt has well done works on disease history. So my work departs from all of these focus to focusing on the healthcare personnel as workers within colonial system. This work shifts the historical base from a disentangled narrative in colonial medical historiography to the underexplored experience of African healthcare workers. In this case, they include medical officers, personnel, and even medical students. As we all know that even in post-colonial Nigeria, medical students, serve as let me say, I don't know the most, but they serve in the healthcare system. Of course, so within the colonial Nigerian medical sector. So I'll say that this work is an ongoing research, but so far so good. My work builds on the following. Number one is the post-colonial medical historiography, which has often, emphasized institutional policy over individual and labor experience of healthcare workers, and also the kinds of medical historiography by scholars like Bond, Perides Leon, John Leaf, Tim Pomerov, which has focused on disease history, colonial medicine. I'm moving away from that to focusing on African medical workers' lived realities during colonial Nigeria. Of course, my work also emphasizes or re-echo the argument or debate by scholars like Bond, who has shine a bright light on the limits of colonial biomedicine during this period. So, what are the questions guiding my research? The first is that I want to actually, know that one, what were the working and the training conditions of colonial healthcare workers during this period? Interestingly, while exploring these archival materials, I discovered that there were disparities between the North and the South provinces in terms of healthcare experiences during this period. So I really want to probe into all of this. Here in the course of the work done so far, I have some thematic concerns and focus. The first one is labor and welfare in the medical sector. Yes, we have read about the 1949 coal mine workers strike in Nigeria, but there's been little attention on the labor condition of those within the medical sector. And so I want to focus on that aspect. One is that in the canons of medical historiography, colonial medicine has been framed as extractive and racialized. I agree. But given that I also historicize healthcare workers as subject of labor exploitation and resilience, I also want to look at the underfunding of healthcare infrastructures, which led to tensions in terms of staffing and some logistics and trade. Trying to see how we can. Another interesting theme I'm looking at is imperial biomedicine versus indigenous systems. So I highlight how indigenous medicine was legitimized, yet relied upon in practice, revealing contradictions in colonial policy. For instance, one of the work I'm also working on the side um, is one that, yes, we're looking at the medical dimension to some diseases, but there are also some spiritual dimension to this. This is based on African beliefs. So here, colonial biomedicine is often limited, and so at the end of the day, we turn to indigenous medicine to save the day. I've not done this, but after this conference, I hope to engage the epistemic violence of colonial science in the next phase of my work. So, given the research done so far, what are my key contributions to this discourse? The first is I want to spotlight what I call the labor history of medicine. Here, using underexploited colonial records, I want to reconstruct the lived experience and systemic inequalities faced by African health workers. Here, I also reframe healthcare personnel as industrial workers who are often subjected to exploitation and marginalization. And of course, my work is interdisciplinary in the sense that it reaches medical history, labor studies, and post-colonial theory to interrogate the political economy of colonial healthcare delivery. Yes, I mean, from the work done so far, I'm also critiquing what I've also done from the feedback I've gotten. The first is the discussion on agency versus victimhood of African health workers. So our African health workers, agents are not just colonial victims. I'm also looking at the gender dimension to this work, and of course, I also want to look at the comparative analysis. How does, for instance, Nigeria compare with other British colonies like Ghana or Kenya in colonial healthcare labor history? Thank you.
I mean, that was so fast. Like, you saved us like almost 4 minutes, or 5 minutes. And which makes a lot of sense. Yeah. Thank you for taking the time. Yeah. So I will just go ahead for my own presentation and the next question on the program. So I'll just go ahead and take it. So can I have the screen? Okay, well, we're waiting for that. My presentation is on colonial health propaganda, public health campaigns on maternal and infant welfare in southwestern Nigeria. So, I would like to start by saying that it's actually an infant idea that I got in the course of one of the course work I did in my first year, and I thought about exploring that aspect of medical history and see what I can bring out from it. But of course, I find it quite interesting because my research interest is on maternal health. Even though for my doctoral degree, I'm looking into postnatal care, and looking at the intersection of postnatal of traditional medicine and biomedicine in the in providing postnatal care for women in Nigeria, especially in southwestern Nigeria. But I thought about, I did an historiographical essay on this, and I realized that, of course, there were public health campaigns, and then some of these campaigns actually were some kind of colonial health propaganda, which were used to subject African women, especially in southwestern Nigeria, which is my focus area, to accept more like a method of control, and then to control these people, and then to subject them to colonialism. So by way of introduction, before I go into introduction, so I would say that this is an different idea I am still hoping to develop, and as a result of this, questions, suggestions, comments that you think would this one can benefit from are highly welcome. So by way of introduction, I would say that maternal and infant welfare maternal and infant health fell under increasing scrutiny from both colonial authorities and Christian nations. So, and this was because of the fact that maternal and infant mortality rates were at an alarming rate from health policy perspective. And of course, it posed a serious challenge to British administrative control. So these health outcomes were through the lens of civilizing nation and ideology that insisted on Western intervention, and that the fact that Western intervention was not only desirable but also necessary for the well-being of colonial subjects. So the whole idea of this paper is actually to investigate the role of health propaganda campaigns in southwestern Nigeria, and then I want to focus on the methods through which these campaigns were implemented, how the messages were conveyed, and then the responses of women to this campaign, because of course we cannot rule out the fact that women they responded at some point, either through resistance or through acceptance. So women responded to these campaigns and then through to this propaganda. So this research, this work will draw on archival documents, the dictionary reports, and then oral histories. So the whole idea of this is to underscore how health campaigns were more than pure health initiatives, and how they became tools for extending British administrative power, reshaping health practices, and also forming the colonial enterprise as a form of humanitarian intervention. So I want to briefly give a historical background to this. So the British role and health policy in southwestern Nigeria. I mean, the primary aim of the British policies in Nigeria generally was to maximize profits and then to consolidate control. Therefore, healthy and productive population was required to achieve British economic goals in Africa. So with the rising maternal and infant mortality, it appeared that the mortality rates were undermining this objective. And of course, this called into question the ability of the colonial states to govern effectively. So colonial health policy was influenced by a combination of racial bias and then pragmatic politics. So, and this was because the British health practitioners viewed the health of their subjects in racialized framework, and that Africa was often depicted as the white man's grave, or in place of disease and danger, and then consequently health initiatives were frequently designed not in collaboration with local practitioners, but against traditional practitioners. So, in other words, there was a conflict between medicine, British colonial medicine, orthodox medicine, and then traditional medicine and traditional practices. So this work would also look into this conflict and how these conflicts were able to probably reach a compromise or reach a compromise. So, and then also there was also the role of the Christian missionaries, right? The Christian missions were key collaborators in delivering healthcare, and not just healthcare, also education in southwestern Nigeria. And prominent among these Christian missionaries were the Church of Missionary Society, CMS, and then we also have the Baptist Mission, and then the Roman Catholic Mission. And all of these missionaries maintained health facilities alongside their churches and their schools. So they had doctors, they had nurses who were often mostly European trade or British trade, and then of course they provided vaccine, treated diseases, and then assisted in childbirth. And of course, they began to introduce Western health practices into rural communities. So the health propaganda itself and then the public health campaigns, this to bring health messages to the population, colonial health authorities and missions relied. I'm sorry, time for me. Thank you. So colonial health authorities and missions, they relied on a range of communication strategies designed to maximize their reach and their influence. And one of those communication tools that was adopted was through posters and pamphlet campaigns, whereby they had printed materials that served as key medium for spreading health messages. So there were poster campaigns. Thank you. There were poster campaigns typically relied on simplified images or a healthy or bed care for baby, and then placed alongside with a sick or malnourished baby. And the whole idea of this was to underscore the benefits of following health instructions. So pamphlets were distributed at health centers, in churches, at marketplaces, and then most of these pamphlets actually provided more extensive information on breastfeeding, hygiene, vaccines, and then delivery practices. Then most of these materials were either written in English or in local languages. In the case of Yoruba, they were written in Yoruba. In other parts of Nigeria, Hausa, or were written in Igbo. And then the whole idea was to reflect an understanding. Of course, however, it was limited. And then to reflect an understanding that messages were more effective when tailored to the linguistic context of their intended recipients. So, nevertheless, of course, the messages remain profoundly influenced by British view of LD and then British view of health and then hygiene. So, and then, of course, traditional practices were uniformly depicted as, dangerous, unhygienic, and then responsible for poor health outcomes. Then another method that was adopted was the use of public lectures and then health fairs, whereby you have public health workers frequently held lectures and health fairs in most importantly in villages and whereby you have Western trained, European trained nurses and doctors demonstrated proper delivery techniques. In the case of childbirth, demonstrating proper care, and then of course sanitary displays were also adopted. Then you have women where you have a situation whereby women were encouraged to bring their infants to be weighed and examined, and then they have what was called the baby show, whereby it was a baby fair, whereby there was a display of babies, healthy babies. So, and then vaccination and all of that. Then there was also towards the mid 20th century, especially from the 1930s onward, the colonial missions and administration also began to employ radio messages, whereby there were jingles in order to reach a wider and more dispersed population. So there were also radio programs that were scripted to convey health messages in simple and clear terms, emphasizing vaccines, proper childbirth practices, and also hygiene. And then most of these radio messages were broadcasted in English at the same time in local languages. So the medium of radio was actually particularly powerful in southwestern Nigeria. Why? 5 minutes ago. Why? Because literacy was limited. So it allowed health messages to permeate homes and villages without reliance on the ability to read a poster or a pamphlet. And of course, at some point, there was a framing of traditional practices versus health, Western health messages. So these health campaigns in southwestern Nigeria were profoundly, influenced by British attitudes towards African and its traditions. So particularly traditional health practices. So especially those related to childbirth, postnatal care, and then hygiene. So this framework was not a neutral, but it was a powerful form of discursive domination. So by framing indigenous knowledge as flawed and dangerous, colonial authorities challenged its credibility, and this paved the way for the imposition of Western framework. So, for instance, traditional birth attendants were described in health pamphlets and reports as untrained and then superstitious, and that they were responsible for the spread of diseases, infections, and of course causing complications during delivery. So women were encouraged to, kind of abandon the services of these local traditional health practitioners, especially the traditional birth attendants, and to embrace maternity care from the Western medicine and the maternity hospitals that were staffed by Western trained nurses and doctors. So there was from my reading at least from the survey I did, there was a whole lot going at the same time, conflict between traditional medicine, traditional health practices, and then colonial medicine. So I intend to go deep into this to uncover how these conflicts were either resolved or adapted into or managed into the system. And of course, I'll quickly talk about women's responses to all of this. So women responses to this were either through adaptation, negotiation, and then resistance. Of course, they resisted some of these health practices. So in terms of adaptation, some of them incorporated certain aspects of Western healthcare into their routines alongside their traditional practices. Then for negotiation, there were other women who challenged the health messages by choosing when and where to apply them. And then, for example, many preferred to give birth at home under the supervision of traditional birth attendants, but of course would bring their infants to health centers afterwards for vaccines and then for checkups, right? Especially the 6 weeks postpartum checkup. Then in terms of resistance, some communities in southwestern Nigeria, they openly resisted health campaigns, and some women avoided the health fears and of course refused outrightly vaccines. And then, so in conclusion, let me just jump into the conclusion. Health campaigns that unfolded in southwestern Nigeria during the first half of the 20th century illuminate a key paradox in British colonial policy. So on the surface, these campaigns were designed to reduce maternal and infant welfare, to combat disease, and then to improve health outcomes. But upon closer inspection, we find out that it was a complex intervention, one that was profoundly political in nature, and then was also used as a means to consolidate British control and also undermine traditional structures of healthcare and knowledge. Thank you.
So I have to give her a whole lot of time because she's talking about women, and look at home women, so that it doesn't look like we have to start another protest here.
No, I will not.
All right, so we can go to the next presenter online. CCQ is not back, so I have to let's have time. The fourth person is not there, but let's just get it.
Okay.
Yeah.
Can you hear me, please?
Your time starts now.
Yes, we can hear you.
Minutes.
Okay, it's as if I'm the only one online. I'm going to be as fast as possible. My name is Ononiwo Param, a graduate student of University of Nigeria and Nsukka. Co-authored the paper with Rosemary Apan, a graduate student of Marquette University, in US. The topic is the changing nature of British colonial industrial policy in the eastern region of Nigeria, starting from 1939 to 1960. Now I'm going to briefly summarize the abstract, then go into little details and policy impact, then draw conclusion. Now, throughout British colonization of Nigeria and the eastern region of Nigeria in particular, the industrial policies of the imperialists changed according to their needs at the time. For instance, between 1900 and 1938, this was a period of exploration, exploitation, and evacuation of materials to metropolitan London. Then the period 1939 to 1945 was a time of intense effort by the British colonial government to support the war effort and expedite the evacuation of raw materials from eastern region of Nigeria, which was in dire need. Now, the era of 1945 to 1960 was marked by the British colonial government recovery effort from the war on the one hand, and the plan for a final exit that would signal the end of colonialism on the other. Now, additionally, this study aimed to examine the evolving nature of British industrial policy in the eastern region of Nigeria during the period under investigation. The research method is qualitative, incorporated with descriptive approaches, and corroborated with archival materials and secondary sources. Now, we observe that the level of change in the British government policy in the eastern region of Nigeria was conspicuous, as the imperial government in London was responding to its current need at a point in time. Now, the study also concludes that if industry is defined as conception of ideas to solve production problem, one would argue that industry never existed in the eastern region of Nigeria during colonial period. Now, let me move quickly to some point so that when we say industry never existed or the changes, how did they change? What were they looking for? Now, we have good knowledge of colonialism. And for purpose of this paper, we are going to look at the relationship between indigenous people and the majority, indigenous people who are the majority and minority of foreign invaders for exploitation of their resources. Now, Rodney also talked about colonialism, where he said that it has one essential purpose, which was the repatriation of the profit made from the colonized people to the so-called mother country. There is also Marxist view of colonialism, where they tend to link it with capitalism. They said colonialism is a form of capitalism that enforces exploitation and social inequality. And as a result, colonialism is closely related to uneven development. Now, it's also a connection or nexus between colonialism and imperialism. They said, we know that a colony is a part of an empire, and so colonialism is related to imperialism. Imperialism is the concept, while colonialism is the practice. So in this case, colonialism is the handmaid of imperialism. Now, in the case, we have four major types of colonialism: settlers colonialism, exploitation colonialism, surrogate colonialism, internal colonialism. Without wasting time, where Nigeria is properly situated during colonial period is what we know as settlers colonialism. Now, currently, in most colonial of Nigeria, Nigeria is also facing what we refer as internal colonialism. Now, the issue in question, as they wrote in their papers, in the archives, colonial documents, official government papers about industry. What actually is industry? Now, we said industry means the conception of ideas to solve production problem. The key to industrialization is the ability to transform knowledge or ideas into reality. Technological transfer is not industrialization, regardless of how sophisticated the technology appears. Instead, where the technology is patented, that's where the secret knowledge of the idea behind the technology invention is held. Now, when we talk about industrialization, yes, it's a process of transforming an economy from one that is primarily agrarian and labor-intensive to one dominated by a mechanized manufacturing economy. It involves the development of machines for factories, urbanization growth, technological advancement, and a shift in labor dynamics. Now, to be industrialized, the idea must spring from the soil. It must be homegrown, which in turn produce high-tech manufacturing. That means manufacturing is a byproduct of industrialization. It implies that factory or manufacturing are at the tail end of industrialization. It was on this basis that we argue strongly that the Eastern Nigerian colonial period did not witness any form of industrialization in its traditional sense, not even manufacturing, which is a byproduct of industrialization. What was littered all over the region during the period of integration were processing plants that fed the manufacturing outlets in Europe. Now, when we look at the changes we have mentioned earlier, their changes was in three phases. The first phase from 1900 to 39, which was just by period of extraction, extractive industry, as they called it, which was not actually an industry. They extracting the raw materials, taking it to Europe. Now, by 1939 to 1945, the second phase of the change occurred. They quickly repositioned and started amending some certain issues by not just extracting, by establishing processing plants in Eastern region that enabled them to package these raw materials in a proper way and have more weight and more well packaged and extract more to be able to ship it down to London easily. Now, when we look at the coal mining, from example we gave, coal was actually discovered in Enugu by 1909. What they actually did was to quickly construct a railway that led to the establishment of Port Harcourt in 1912 for easy evacuation. Now, they were actually using coal at the point to power the mining sector, the railway line, and try to use it to also power electricity. But by 1939 to 1945, many things changed in the coal mining industry. They started exporting coal outside Eastern region. They were now using it to power all the colonial settlements where they settled in West Africa and also to Europe. But unfortunately, the carbon content of coal in the Eastern region was not actually better than what they had in Europe. So they had to pipe low to the extent that it was not until 1950 that the Nigerian Railway Corporation now established what they call Nigerian Coal Corporation in 1950 for the purpose of extracting coal. Now, we have three major coal mining in Enugu. We have the Obireti coal mining site, we have the Eva, we have the highest, where we are giving the output of 12,000 tons, 750 tons, 250 tons, respectively. But by 1957, coal production in Nigeria had actually increased from 582,000 tons to its highest peak of 925,000 tons in 1958. Now, when we talk about extractive industry, as they were referring it, they are the process, because of the mission was very clear, economic interest. Now, economic interest, what actually are they doing in Eastern region? Is it to please the people and organize administration? The answer is no. They were looking for something to take away back home, because that's what the mission was all about. Every other agenda country, the road they built, the railway line, water, hospital, whatever they built was for the convenience of the colonial government authorities. Now, for limestone, they discovered limestone around Enugu, Abakaliki axis. And at the time, by 1900 to 1939, they had no much in need of limestone. But during the war, they had reason to make use of limestone. Like in 1941, that was a period they discovered limestone in a large quantity in Nkago area. Then by 1950, local cement manufacturing was considered after a large deposit of suitable quality were discovered at Nkalago and Agu Division. Now, 1954, the negotiation was somehow completed between the colonial government and two United Kingdom firms, a cement manufacturer and a consulting engineer, to establish a cement factory at Nkalago. Now, as the colonial authority did not hesitate to construct roads and railway lines to evacuate the product, then the cement factory was formally opened in 1957. Now, for oil palm produced in oil milling process, that is palm oil, they were not much interested at the early period of colonialism. But as we observe, by 1939, many things changed. They had a need of trying to get as much as palm oil as possible. Before 1939, palm oil was also in the hands of individuals, private individuals, and plantation estate, and maybe accounted for only about 6 to 7% of Nigerian output. The remaining were in the hands of individuals. But they made effort during the war and after the war, especially in 1949, to establish what they call developing pioneer oil mills in the southeastern region of Nigeria. Now, the Eastern Region Production Development Board championed this cause by establishing the pioneer oil mills on 23rd June 1949, and the colonial officer was in charge, who was the chairman of the board. They established this one at a place called Amuro near Okigwe and began operation in 1946. Because of the success, they ordered for more of the processing plants to be established in the Nigeria, not only Eastern region. And 18 were earmarked for Eastern region out of 27 that was ordered for the whole of Nigeria. By 1949, 6 oil industries, oil processing plants, has been erected at Amanse, Amuro, Muchima, Ahoda, Azumini, and Bobio, which is River State, part of the region. Now, they also, okay.
Can you just round up?
Sorry, let me round up. Okay. In conclusion, what we are trying to establish is that from the interrogation we had and what we examined is that there were 3 phases of changes according to the British colonial interests regarding the policy of industrialization in Eastern region of Nigeria. And each was a result of their need at that particular point in time. Now, the Eastern regional government with an indigenous majority, like when Latency Constitution was established in 1954, changed a lot of things because it gave overwhelming indigenous majority in the Legislative and Executive Council. It was only in 1954 that the indigenous tried to structure the economic policy of the region. Now, the Eastern region colonial period did not witness any form of industrialization as I pointed earlier in actual sense until the twilight of the colonialism, not even manufacturing, which is a byproduct of industrialization. Finally, the point is that even though colonial records referred to policies regarding the extraction of raw materials and establishment of processing plants as industrial policies, they still did not constitute actual industry. Thank you.
Yeah. Yeah, thank you so much for the Julian. So before I have a couple of comments, but before I give you a comment, I would like to throw it into the audience. Questions, comments, suggestions. Yes. Exactly.
Thank you. Great presentations, all of you. I have just I have got some questions for the so I'll start with Ivan. I don't know if you've watched this short Doctor in Nigeria. It was I think it was done by used by the British Film Institute that is something still. Maybe that might give you other insights to watch quickly. I could deduce from your presentation that it's an ongoing study, but I will still pose this question. I don't know if in your preliminary phase of research, were there indications that some of these health papers in African health papers, were there indications that some of them were very exposed to certain geographic locations? Right, maybe they prefer to work in Lagos, both one remote, rural. So that's looking at it from a geographic perspective. And then that's another by me. In the introduction, you mentioned that there was high maternal mortality rates at the time. Yeah, so I would have preferred various of statistics. Yeah, those two for ground that point, especially from the records. And then also, what was responsible for high mortality? Because again, we need to avoid temptation to romanticize colonial medicine. Because there's a book I'm currently reading between peace and famine. And it was done by a priest in Glasgow. And made us to realize that colonial medicine itself brought a lot of disruptions to the African society. It did more harm than good. All right. I mean, for instance, a lot of people breast milk substitutes were introduced to the African society. African women have been breastfeeding their children for a very long period of time. And then later they came and they felt that, no, this is not ideal. Let's have breast milk substitutes instead. Right. So I think we need to also look at that problem. Then also, there was a point that, let's say, you spoke about visual artifacts, posters, and all, because I did a presentation earlier today trying to tell the story of public health in Nigeria, posters and stamps. Right, so I was so pleased to get that. So, again, I don't know if you have these artifacts, so I've also been nice that added them to this story presentation. So it's going to be able to reinforce many of the very interesting facts. Thank you very much, and all the best.
Thank you so much. And I think we should just take all the questions and then the panelists can respond. Yes, thanks.
Thank you. Thank you all for your presentations. I just had a couple of questions for Ali Wale and for you, Gummy. I'll just start with Ali Wale. I was wondering, have you researched far enough to see where the medical professionals, like their demographic, so their ethnicities, their status, whether they eat, whether they train, they come from work, they made up the medical or the labor of the employee that are healthcare system. So I wanted to know more about the people themselves and where they came from and who they are. I wanted to ask, you mentioned that you're departing from the existing literature on like the Comoros and other good stuff and colonial medicine by focusing on the labor. But in their analysis that colonial medicine was contracted and racialized, did they touch, even though that wasn't the focus or angle of their work, did they touch on labor? Did you get any insight from that literature on labor positions that are guiding your questions, or what you couldn't discern from that literature that is shaping your question? So those are just wondering about. And then Lola, I think this topic is really fascinating. I'm glad you're taking it on. I guess one comment I have is, I think we're all like, yes, you know, the colonizers are the bad guys, but to lay it out, like, you made claims that that the medicine was a tool of control and trying to do all these things, but I didn't see. I saw the communication strategy, but it just sounds like a good healthcare campaign, you know, like a good public health campaign, but so what, if you could, like the smoking gun, like in terms of what they were trying to accomplish by stigmatizing traditional medicine. You know, what was the problem that they were facing that they sought to do this? Just some more evidence of that. And let me see. Oh, I was wondering, we've only made an offhand comment about traditional medicine being stigmatized but utilized. And I was wondering if you had come across that in your research on the way women and were participating in traditional medicine. You know, how they weren't utilized and stigmatized on one hand, but they were actually being midwives in a hospital, or was it like a example, like just rejected, we're not using any medicine or not? I didn't know if you had come across that, so I was just, that just came up when you mentioned that, so I was wondering about that. See, any other? Oh, and just and then I guess a comment, but also a question. Just framing it in terms of the existing literature. Has anyone studied this at all, and what does that literature say? And, you know, kind of where your intervention is clear, but I don't know where it sits in relation to the existing research done in this area, or is it totally brand new? So that I just wanted to frame the existing.
Thank you so much. Yeah. Any other case?
My contribution, I'm just trying to look at it. It's kind of collaboration from the church. I want from this perspective, the church, the Anglican Church, for example, and the seem to have collaborated colonial masters in achieving their goal. But when it comes to practice mission, it wasn't that way, because Anglican Church is like a subset of colonial, but the practice and the Roman Catholic. So I want you to navigate and be a clear cost out of their relationship. But the way they play their role is not the same process of achieving the goal. And then I want you to also look at the area of analyzing. But analyzing any that like the German would be better to emphasize the place of analyzing the functioning their policies that want to something that is to Africans and see how it's going. Excellent. That's been a wonderful and listening to you.
Thank you so much. So, any other comment? Okay, so I guess we can respond to the comments, the questions. So, thank you.
Okay, thank you so much. A very dear mentor, Shine for that. It's always, you know, there's this bias everybody brings sometimes. You don't know, but it's just part of you that you bring to the intellectual garden like this, where your discipline always, you know, will always speak in the comment that you made or the question that you ask. Is a medical geographer, so we'll talk about geography. So, yeah, about this comment and question that if workers were willing to or were highly interested in working in certain places and in geographical dimensions. Yeah, so far I discovered one that I mean, there were more in terms of infrastructure, there were more infrastructures, you know, developed, constructed in the southern province, most especially in Lagos. Many times, infrastructures were developed or constructed in places where the disease became, infectious, or it became very epidemic, as the case may be. So if there was no case of, like you said, health tension in certain communities, there was no need for developing infrastructures in those areas. The same thing for healthcare personnel. So if there was no health crisis in certain communities, outside of Lagos, especially during the colonial period, to the colonial authorities, there was no need for them to post, medical officers to those regions. So I also discovered that in geographical dimensions, even to how diseases, spread during the period. For instance, during one of my studies, separate from this, I discovered that some diseases were particular to some geographical areas compared to some areas. For instance, while studying venereal disease, I discovered that gonorrhea was common in southern Nigeria, while syphilis was not common in the northern province at the time. So yeah, I agree that there were geographical, dynamics to these issues. Yeah, and just like I think that also, spilled into the post-colonial period. Just like we have it now, that people would want to work in places like Lagos, even beyond healthcare. People want to work in Lagos, they want to work in those, those cities, as the case may be, those urban centers. But that got, where the oil money is, as the case may be. So I think I didn't discover that in the course of my research, but I can assume that this is a spillover of what happened in the colonial period. There were areas where it was interesting to work, even as healthcare workers. Of course, there are also challenges. I remember that in the 1920s, Dr. Sapara was making a lot of comment as regards the experiences dealing with some certain health issues in Lagos, because he was based in Lagos at the time. So yeah, I'll go deep further on that. But yes, I agree that there was geographical dynamics to it. So you mentioned that who are those who made up the Lagos system? Yeah, during the course of my presentation, I mentioned that I discussed the demography. It included healthcare workers, medical students. For instance, the gender dimension to my work, for instance, in terms of the demographic analysis, I was unable to really dig into the proportion of male to female, as the case would be. But yeah, in short, even in 1949, due to the development at the time, there was a protest by the Pharmaceutical Student Association in Lagos, who protested against the British government due to the reduction in their what we now call stipend. Yeah, due to reduction in their stipend. In 1947, for example, they were earning, say, £8, and by 1949, the British Colonial Authority reduced their stipend to £5, 5 shillings. And this medical student, not even the main healthcare personnel, that is, the African, those who are in the system fully, just the student, during this period, mobilized and insisted, the reduction in their stipend. So the demographic consisted of workers, those who are in the system as, fully employed workers. Students were also, medical students were also part of the demography at the time. Of course, side by side, especially during the first 3 decades of the 20th century, there were European health workers who were, on the ground doing some health interventions across various places, was dominant in Lagos. The third question, that's what I can say so far. Yeah. Yeah, you also asked that. Did the literature focus on labor issues? Yeah. Did a bond work on titled "Curing Their Heels"? Yeah, she touched on some but it wasn't a dominant focus. It was just some sort of just some concise broaching of of this labor issue, but it wasn't the core focus for the work. But I discovered that while reading the chapter 6 on about on syphilis, for instance, we're talking about the limit of colonial biomedicine. She just briefly touched on that, but it wasn't the core focus. Well, of course, I read that and then going through the annual report for 1921, and so I could like put the puzzle together. I'm like, okay, there's a need to actually dig deep into this labor dimension, if not for a certain level kind of research, but at least for a journal paper research. So, and that's why I'm actually focusing more on the labor dimension, which is something that most of them have not really focused on extensively. I think those are the questions I got. Thank you so much for that.
I was trying to respond to the question. He mentioned the issue of the question raised by Professor and in the choice, yes, of location. So as we were talking, I informed me that there could be a kind of narration of movement. Okay, it did not actually start with making choices. Were posted. Okay. Thereafter, we had choices. So, an issue of choice might be coming when we had large number of trained medical personnel, and that could be maybe after 1960s. So before 1960, we cannot talk about they making choice, but we talk about they being posted.
Thank you so much.
Yeah, thank you for the comment. So I'm just going to jump into my some of the issues raised concerning my presentation. And I want to say that I want to both of you, sir and Mark, for the questions and then for the wonderful contributions. And like I said at the beginning of my presentation, this is just like an infant idea that I'm still trying to develop. But of course, for the purpose of this presentation, I think I read some books and I which might solve it for me to at least be able to project the idea of this presentation. And then the question about statistics on high mortality rate, yes, I agree with you that it would have helped this presentation. And then of course, my plan for coming to Nigeria actually this period is primarily to visit, to attend this LSE conference, and then to get into the archives, right? So I'm hoping that I will see, apart from what I'm able to read in books, I'll be able to get concrete evidence from the archives as regards statistics on infants and maternal mortality rates. Yes. Oh, thank you. So thank you. So it's just showing me that it has this. So I'm going to liaise with him and then go get that. I mean, that's the beauty of that's the beauty of coming to a conference. Yeah. So thank you for offering your help. So yeah, thank you for that. And then you mentioned that what was responsible for high mortality rates during this period. What I can deduce from that is that high mortality rates in colonial Nigeria was driven by several factors, ranging from epidemiological factor to socio-economic factor to environmental factor. For instance, in terms of epidemics, there were new diseases that were brought by that were associated with colonialism, and all of this brought about an increased interaction with Europeans and other parts of the world, and then thereby introducing new diseases like smallpox, syphilis, influenza into the local population in Nigeria. I'll take, for instance, the smallpox epidemics because I've done a lot of work on smallpox. Smallpox was a pandemic and it affected every part of Nigeria in terms of its mortality rate. The same thing for influenza of the 1918, 1919, it affected the whole lot of people. And then there was also other endemic diseases like malaria, yellow fever, and all of the sleeping sickness too. And all of these were already widespread, and then they were often fatal due to lack of effective treatment and then management. Then also in terms of public health infrastructures, as at this period there was poor public health infrastructures and then of course what the colonial government did in order, because we know that the primary reason for colonialism was for the Europeans' economic gain. So if they have deceased population, it is really going to affect that ultimate goal of colonialism. So they began to put measures in place in order, and that was why I made the statement of controlling the population for the ultimate goal of colonialism. So then also the issue of sanitation was also a major problem. And that was why they began to tag all these traditional healthcare practices as unhygienic, superstitious, and all of that in order to have control over. So what I was trying to project is that I am not trying to romance colonial medicine. I'm not trying to romance colonial medicine, of course. And just like they say, colonial medicine did more harm than good. I agree totally with that. So I am not trying to romance. As a matter of fact, I'm trying to what I'm trying to look at is majorly how these health campaigns and then propaganda were they actually received by the people? Were they resisted, or were they resisted, or I mean that's what I'm trying to that's what I'm trying to bring out in this conversation. Then the question of artifacts and posters and stamps, I understand that we have a lot of them in the archives, and it still boils down to me visiting the archives to dig out all of this as evidences to whatever I am claiming in my paper. So I'm going to go back. Then you have a question about what problem with the European facing beyond stigmatization. Did I get that?
No, just in terms of the control. So I know about like sanitary segregation and things like that. Just wondering, like, what were they trying to accomplish by stigmatizing?
Okay.
Yeah, like what was the control they were trying to exert?
Oh yeah, I get that. I mean, the control, from my understanding from different texts that I've read, was actually to subjugate and also exercise their dominance in order for the ultimate goal of economic gains. Yeah. And then your question about literature in this area, of course, there are a lot of literatures in this area, especially on health campaigns and then health propaganda. For instance, at the Arnold, colonizing the body, state medicine and epidemic disease in the 19th century India. Yeah. And then also Megaphone, also a good source. Then Jane Kumarov is also a good source. And then, of course, Nancy Rose Holmes, she did extensive work on colonial medicine. And then most of our work also talked about health propagandas and all of that. And then also, I also understand that current claims, work on aid traditions, African medicine, cultural exchange, competition in South Africa. Also a good source. And these are some of the ones that I agree in order to put this presentation together.
Sorry, before we go,
Sorry, please.
okay.
Yes, I still have to respond. Yeah, the sense of the, I mean, that was an interesting comment, which I have taken notes as regards the part estimation and trying to verify the processes of their what their processes of their involvement. So I am going to look into that and then put that also in situation. So thank you so much.
Yeah, thank you. I have a question for you, of course. And I have a question for everyone, of course. So, and I actually want your comment on the question I have for everybody in the room, including chair, so that I can really, dig into my work. So my work title, I'm sure we all have the brochure you read, title, to bear the black man's body. Like I said, this points to the racialization of the medical experiences during the period. So I want to read the paragraph again, and then I want to ask a question. So the paragraph I got the quote from says, although in the foregoing paragraphs, an effort has been made to paint the conditions in which our medical staff in remote outstations strive, in quote, to bear the black man's body. It is difficult to give an adequate picture. So I have the question here, which I've been thinking about, but I've not been able to answer. What brought I don't know if you understand the context. The principal medical officer is trying to paint here that their medical staff within the remote, outstations outside of Lagos, are trying to bear the black man's body. So, of course, in the context of health and wellness, as case may be. So I'm trying to understand what bodies do. What bodies is this medical officer trying to talk about? We have bodies as Africans. My thinking was that, before this period, Africans had indigenous health systems that address various health conditions. And I do not think that this post some sort of burdens on indigenous or national health workers. So if a colonial principal medical officer is reporting to say, to bear the black man's body. So does it mean that the white man does not have bodies? These questions are just what I have. I don't know if we have comments. Yeah. Okay. I'm sorry. My question to Dr. Dami, why she thinks is that just like we are doing the COVID scholar is here. Just like we have propaganda during the COVID period, figures were inflated. We don't even know if the figures were real. So I'll ask you, the propaganda that existed during this period, what was the we know that during the COVID was to get more money or to paint pictures that Lagos is a red zone, as case may be. And in places like Kogi and Cross River, the government said that there was no COVID at all, there's nothing here, and they got money. So, so the propaganda during this period, what was the end goal? Yeah, I would like to know.
Okay, should I think we should respond.
Yeah, so that's why you process that. So, what body?
Let me cite this to showcase anybody. During my window, when I was in my I had to travel from Shaki from other area. We were packed like and in the car. So when the car closed from the car, the boots were opened, those were dead, and then those were also flat. And everything was filled up. We sat a space normally for 4 people and 3 persons. We sat 4. The driver also had extra 2. So every place was full. And then I now try to connect. When I traveled like 3 years ago. And when they came then, how the roads went. The roads were terribly bad. No water, nothing. And I even got one of the facilities built by the Baptist Mission. imagine, so in coming from that perspective of the rigor and the stress they had to go through in order for them to give health, give wellness to Africans. So the environment and the road to the place, and they might be provided with cars or facilities to move them, but there might be some places they might not be able to take their cars to, and they might have to trek, and it's not going to be just a day journey. Like before, every other person in my area of study, Shaki, in or Kaka, not like they will all travel from, if you are coming from Shaki, you are coming from 34 to Gumasho. So you can imagine how it will be. And then they getting to them, and they will be then, we need your attention now. Even this day, when we get to the hospital and we are asking for assistance, we want your attention immediate. So giving delivery be according to, and then assessing the people also could be a body, because there will be a level, there will be a place that they will not be able to make do with convenience, that they will need to stress themselves getting there. And then, the general notion where even when it comes to medicine is that mosquito is not their friend, it's also a body. Okay.
I'll just say to watch that document.
Okay.
And I will also have
I'll
that.
be starting my conference. I'm in a conference session.
Can you please mute yourself, Dr. Ononiwo?
Okay, so I would also add that I think this body is about organization of the health and the issue of control. Therefore, it will become also racial hierarchies. So you may want to consider this, because if we look at it, colonial health systems actually prioritize the health of Ethiopian settler administrators and soldiers over that of Africa. And whatever they did for Africans as far as healthcare is concerned, is what some scholars have tagged as symbolic gestures. So you may want to look at that from that angle. So I feel it's going to help. So any other comments on that before I respond to your question? Okay, so you were asking about the aim of colonial health and if I get to your question, right? Yeah, so I will just say that it was a multifaceted kind of thing. It served both imperial interests, and at the same time, it also served public health objectives. So I would say that the aim was, number one, to legitimize colonial control. Then I would also say that to improve labor productivity and also to promote Western medical practices. And of course, at that time, to also control epidemics. So basically, that's what I would.
There's no financial dimension, like, getting, more support from bodies like the Rockefeller Foundation at any point in time, or other bodies that intervene in certain areas?
I may not be able to give a specific answer to that.
I'm trying in most of my work, I like to follow the money, because one of my interests is financing of this. So I also look at the money part of it. Was these pictures or painted in a way that Rockefeller brings the money, or
Well, of course, from one of the studies I did earlier on, I worked on the Rockefeller Foundation and their involvement in the establishment of pharmaceutical industry. And I would say that there was also a kind of propaganda in that sense in getting the Rockefeller Foundation to fund is to fund establishment of pharmaceutical industries in Nigeria. So we can, of course, take that discussion for that outside this room. So our time is fast spent, and I'm just going to briefly recommend your presentation. So, no, just.
She's my chair.
No, okay, I'm sorry.
No. I'm happy to.
Can I go ahead?
Of
course.
So
it's just a comment, not a question, and I just feel that while you were presenting some of the things I feel was your work, I don't know, depending on your focus and your care, and all of such is to categorize some of this, to categorize this healthcare personnel, categorizing them into the doctors, the nurses, the midwife, the dispensary attendants, and then also, and if you're talking about healthcare personnel, you may want to clarify if we're talking about Western trained healthcare personnel or European healthcare personnel working in Nigeria or traditional healthcare personnel. So if you want to distinguish between that, then we also have African health workers. So you may also want to distinguish that. And then you may also want to look at colonial policies that shape the recruitment, the training, the deployment, and also the welfare of these healthcare workers. So you want to look into that. So thank you. Do we have any other comments online? Any question online?
No.
We have question for.
Oh, we have a question. Yeah.
Oh yeah. So this question is for on a new survey. You can raise and can you hear me?
Yes, I can hear you.
Okay, so the question says, thanks for an enlightening presentation on Noniwa. I'm curious if you are aware of the Oncalago cement factory in the eastern region and how it fits into the frames of your analysis. I understand it was producing 2 million bags of cement annually before independence. So you may want to respond to that.
Yeah, the cement industry, yes, is part of what I looked at. What actually led to it was the discovery of limestone in the Calago area. So let me get something very fast. So the discovery of limestone in the Calago area, the issue of cement industry actually came up around 1949. And before then, they have already discovered limestone in the Calago axis, where the cement industry the person is referring to is still located up to this very day. Now, but nothing was actually done because although they have the cement has two major raw materials to make the limestone and what they call the gypsum. The gypsum was the only raw material that was imported from outside Nigeria. So it was that discovery in the 39 that around 1939-40 that led to the establishment of the Calago cement industry in the 50s. So I'm aware of that. And it was actually in 1950 the local production started. Then by 1954, the British colonial government has actually brought in expatriate consulting engineer and cement manufacturing expatriate from Britain to come and establish the Calago cement industry. Now, by 1957 also, production has risen to a very certain level. Yes. So as usual, what they actually did in Calago, they didn't also waste time to connect a railway line from Port Harcourt to the area for easy evacuation.
Can you hear us, sir?
Yes, I can hear you now.
Okay, so please, Can you just round up and we can.
Yeah. So that was the point I'm trying to make is simple. That when what actually led to the Kalanko cement industry was the discovery of limestone in that area. The discovery of limestone in that area. And it was not until 1954 that the consulting engineers arrived to begin the construction of the cement industry. They didn't kick off until 1957. That was what I said, that there was actually nothing like industry in the eastern Nigeria until the tail end of colonialism, which was actually helped by Leyton Constitution of 1954 that brought in the indigenous majority in the legislative house that now voted for industries to be established in eastern Nigeria. Thank you.
All right, I'll just round up by saying that, thank you to everyone for being a part of this panel. I want to believe that it's been a fruitful and engaging one. So thank you so much.
Thank you.
Thanks for coming.
Thank you, everyone.
All right, it's time to do.
Thank you.